his slots with mine so that Bob Kelly will do the 2 p.m. talk. So my slide will be more busy. It's exactly like the Bulan Puasa Jam, not as big as Bob Kim's slide. So I hope that you have no time to sleep. So I'm going to talk about menopause and tackling special population and gynecological malignancy. Again, promotions for those that didn't pay attention yesterday. My Women International Congress, 50% discount for first 200 registrations. Why menopause matters? Okay, I know that you are going to agree with me. For guys here, if you know menopause, you can prolong your lifespan. Okay, you know how to handle your mother-in-law, you know how to handle your wife. For women, you can live through your menopause more better quality of life. Okay, you also will start understand why your consultant keep on scolding you. I will try not to too much. Okay, aging population, yes, true enough, the numbers of women aged above 60 will be increased from 336 million in 2000 to just over 1 billion in 2050. So we are dealing with an aging population. If you look at the Malaysia demographic statistic in 2024, we already have 3.8 million elderly population aged more than 60. I'm sure the number is probably more than 4 million now. And Malaysia is doing quite well. You can see here life expectancy over the Southeast Asia. Malaysia is after Singapore, Thailand, then third is Malaysia. So we live up to like 77 for female, 72 for male populations. And so this is what happens. We are going to have a lot of menopause women, and with the average age of menopause at 51 years old, okay, or now even earlier, some will say 48, 49, you will get your menopause already. So probably most like, last time we say 1/3, now probably 30 to 40% you will live through your lifespan through menopause. And not surprisingly, you will see a lot of house like that with a lot of aircon. So you can imagine how many menopause women inside the house, mother-in-law, wife, sister-in-law, things like that. Okay? So many women worry about the menopause, okay? Some of them actually do quite well. 50% of them have symptoms affected their quality of life. What we more worry is about late complications like osteoporosis, heart disease, and Alzheimer's disease. So throughout the early stage, they complain of primary symptoms, then intermediates, a few years later, they complain of vaginal symptom, urogyney symptom. So that's how you get your urogyney problems and incontinence, things like that. So people believe that, we used to believe that hot flushes is the top one symptom, but unfortunately it's not longer true. So most of women complaining of joint pain, backache, fatigue, and irritability. So this is probably the top 3 symptoms, no longer hot flushes or insomnia. Okay, this is consistent with the Pan-Asia study over the 13 Asian countries. And this study published by Prof. Bahia from UiTM in 2017. And surprisingly, or not surprisingly, only 25% of women sought treatments despite so many years after the WHI study. And in fact, only 20% took hormone because all the WHI study. And in fact, when we published the data publication last year, 2025, among 1,800 working women, we do see that the main complaint joint pain, backache, sleep disturbance, and brain fog. Okay, if you look at the symptom, I'm sure almost like 80% of you menopause already, right? Back pain. You having back pain? Yes lah, right? Can't sleep, especially before the exam or before the exam. Brain fog almost every day. Brain fog almost every day. Every question ask you, you will like stunned. Look at me. So menopause is very important. Spot diagnosis. So you are menopause, 90% of you. So all these are because of WHI study. Okay, so in 2002, these billions money spent trials came out with all these scary sentence released into the press, and a lot of doctors don't dare to prescribe hormone, a lot of patients don't dare to take hormones. And this is the WHI study published 2002. if we see combinations of estrogen progesterone, so the risk of patients, 10,000 women getting complications, 7 more cardiac events out of 10,000, 8 more stroke out of 10,000, 18 more BTE out of 10,000, 8 more invasive cancer out of 10,000. Unfortunately, the result was expressed in a relative risk. Relative risk means that with the 7 extra cases of cardiac events equal to 30% increased risk, 8 more stroke equal to 41% increased risk, and 18 more BTE equal to 113 increased risk. You tell the woman that you have 100% increased risk of BTE, I am sure no one dare to take hormone. Okay, so this is how we explain to patients. Okay, you can take pregnancy. Okay, among 10,000 women, 60 women get pregnant, might get BTE. The risk of BTE is 60 out of 10,000 women. You take COCP, 10 to 25. So you worry about hormone getting BTE. The answer is very simple: don't pregnant. Okay, you don't pregnant, you won't get the stage 1 cystocele already. So the God tells us you must let go your past. So to be honest to you, after you get pregnant and delivered, almost, I can tell you, 90% of you here will have stage 1 cystocele. Okay, go back and look at the mirror. So it's so common, okay? So those who ask that question, hello, Palawan and above, you are going to have cystocele, stage 1, asymptomatic. So unfortunately, the publication about estrogen-only therapy in those without uterus have a better outcome, but this is not released into the press and not stressed upon. There's no difference in terms of risk of cardiac events, colorectal cancer, breast cancer, and death, and this is not stressed upon by the press. So have many trials actually tell us, indicates that WHI have a lot of cons. Okay, WHI was misinterpreted and misquoted. Okay, because of that, many women have suffered, and many doctors do not dare to prescribe hormones, and we can see so many osteoporosis fracture nowadays. We used to tell that ONG is the richest subspecialty, okay, but no longer true. Okay, you can see now orthopedic is the one that earned a lot, and plastic is the one that earned a lot. Okay, ONG doctor need to stay in government like university to continue to earn money. So global consensus about hormones, we know that a lot of international guidelines agree that hormone is the most effective treatment for menopause hormone. And if we start earlier, if we start at the right patients, it actually gives you more benefits, outweigh the risk. Remember, you must start hormones before the age of 60 or within 10 years of menopause. The earlier that you start the hormones, the safer, the more benefits you get. After 60 years old, no hormones, unless you need to have a thorough discussion and the menopause is really affecting the quality of life. Otherwise, hormone is just a part of oral study to improve the midlife health. And we see here MHT is the most effective treatment for menopause hormones. We know that non-hormonal prevention is okay, but hormone MHT is the one that most effective. Nothing is better than MHT if the patient can be given MHT. MHT reduces osteoporosis-related fractures. You can see here clinical fractures, osteoporotic fractures, and hip fracture reduced as compared to placebo with the use of MHT. Cardiovascular disease, yes, if we start hormone less than 60 years old, the cardiovascular risk is good. It appears to be protective, but unfortunately, more than 60 years old, the risk of BTE, the risk of MI stroke is higher. But unfortunately, despite all that, you cannot use MHT solely for primary prevention of CHP. You also need to start MHT for menopause related, but not solely for primary prevention of cardiovascular disease. So here we see here MHT starts less than 10 years after menopause. In younger women, is protective. However, there is a slight increase in risk of thromboembolic disease. So what I've learned after 2002 until now, 24 years, we learned that age makes the difference. Okay, so you must start menopause hormone at younger age, less than 60, again less than 60. If the woman underwent surgical menopause capsule for whatever disease at 45, 46, is even better than you start the hormone earlier, because the vessel of these young women still good. There's something called estrogen window. So when you start the hormone during this estrogen window, it actually gives you more benefits. More than 60, again, no hormones until you have the thorough discussion that the patient willing to take the risk of stroke and MI. So studying hormone counseling is very important. So risk and benefits should be clearly documented. And there's only 4 FDA-approved indications to treat vasomotor symptoms. Prevention of osteoporosis is almost needed in every woman. So like it or not, you are going to have one indication for prevention of osteoporosis, premature ovarian insufficiency, or treatments of genital urinary syndrome or menopause. Remember, for those with uterus intact, we require progesterone to counteract the effects of estrogen. For those without uterus, we only require estrogen. Except when you underwent surgical menopause for endometriosis, right? Initially you require to start estrogen, progesterone, or tibolone. I'll mention later. And we can see here from our BHI long-term study, if we compare combinations of hormones at all age, okay, combination of hormones in younger women and CE alone at OH and CE alone at younger women. You can see here, cardiovascular risk in younger women actually protective. Okay, we can see here cardioprotective for younger women. Breast cancer, you start only estrogen only, actually it's reduced. The breast cancer risk is reduced. Okay, so deep vein thrombosis, younger woman, better. So you see or not, select your correct patient is important. Second, we can see from the data also, progesterone make the difference, especially you can see here the breast cancer risk. So when you start combinations of estrogen progesterone for those with uterus intact, the risk of breast cancer is higher. But when you only start estrogen for those without uterus, the breast cancer risk is lower. Okay, so that's also an important point. That's why progesterone makes a difference. Because of that, you need to select a good, favorable progesterone. So far, studies have been shown that micronized progesterone, your utrogestan, and dydrogesterone, your dufaston, is the 2 progesterone that you need to choose. If you want to choose combined estrogen progesterone, try to get either dufaston, your dydrogesterone, in the forms of combinations like Famoston 110, 210, or Famoston Conti by Abbott's, or you use utrogestan, vaginal utrogestan, previously by Wellten, now is under EP+. Okay, so you need to select a good progesterone, and studies show that with these 2 progesterone, the breast cancer risk is reduced. So you see or not, when we don't start hormone, the risk is there. Nothing is without risk. Taking PCM also with risk. Taking NSAIDs with risk also. Everything with risk. But we need to choose something that have a lesser risk, has a more favorable outcome, and we now know the facts. So for those registrar that for menopause clinic, every time mention angelic. You see, angelic is not a good progesterone. Right? If you want to use non-bleeding lesion, you have angelic, Famoston, Conti, and tibolone. So the angelic is the last choice. Okay, hopefully that will help. That's why you need to know some knowledge so that you can choose the correct preparations. Okay, we have cyclical MHT, means the bleeding lesion. So bleeding lesion is suitable for those perimenopause with symptoms. You want to start hormones at perimenopause age so that they still acquired their money menses. So this is in the forms of estrogen continuous and progesterone 2 weeks durations. You have Famoston 110, 210s, you have Forgadutons. Okay? With continuous combined MHD, this is the one that non-bleeding lesions. So if the patient comes with perimenopause age group, you start bleeding lesion first until the age of 51, then you change to non-bleeding lesion. Okay? So choosing a correct preparation is important. Estrogen only for those that without uterus already, you can only choose the estrogen only. We have a lot of preparations. We have oral progesterone, we have transdermal estrogen. And you also need to know the difference between transdermal estrogen over oral estrogens. And progesterone only, you have utrogestan, like I mentioned, micronized progesterone. You also have Mirena as a choice. So third thing that we learn is risk of BTE. We know that BTE risk is always higher at the first year of use. So this is important when you counsel the patient. Try not to let them start again. Some people is like that. They start at the 49 years old when they are very healthy, up to 53. They listen to the Makcik Bawang, Makcik Putih, they stop the medication. You also allow them to stop. 55, they want to start again. 57, they meet another groups of Makcik Bawang, stop again. 59, they start again. When you restart the MHD, your risk of BTE is higher. So try to maintain the MHD. Once you start earlier, you can continue until the age of 70 or 80, provided the patient is still healthy. But when you stop, restart again, your risk of BTE is higher. But of course, you don't ask me how long is the duration that you can allow to start and stop. Okay, no one knows that, whether it's 1 month, 2 months, 3 months, or 6 months. Okay. Next, we'll try to use a lower dose of estrogen if possible. And in fact, the next thing that we can do is we use transdermal estrogen. Transdermal estrogen have the 1/4 risk of getting BTE as compared to oral estrogen. Okay. So for those women with uterus, you require estrogen plus progesterone. Your estrogen component can come from transdermal estrogen. Your progesterone component you can come from Mirena or vaginal utrogestan. So this is how you play around with the estrogen component and progesterone component. In the woman without uterus already, you only require transdermal estrogen only if the risk of BTE is high. So you use transdermal estrogen only. In the woman without any higher risk of BTE example, then they can opt for oral estrogen only or transdermal estrogen only, depends on their preference. Some people like to swallow tablets, some people like to apply gel, so it's really up to them. So we learned a lot from WHI that mortality was not increased by MHD use, especially if it starts in the early women less than 60. And management of menopause can be as simple as this diagram only. Okay, from our Malaysia CPC guidelines, if the woman still require contraceptions less than 50 years old, you can actually opt for COCP. Until 50 years old, only you change to menopause hormone. If the contraception is not required and there's no contraindication for MHD, you can consider MHD. So you use your systemic MHD. If the woman at the same time got local vaginal symptoms, you can top up vaginal preparations on top of systemic hormones. If the woman more than 60 years old, only with vaginal symptoms, and you can start vaginal preparation, vaginal estrogen at any time. Vaginal estrogen does not need to fulfill the criteria for systemic hormone. At 70 years old, post-menopause, urogyne or lab or vaginal atrophy, vaginal symptom, you can use gynofor at any time. Okay? So it can be as simple as that. However, not all women can use MHD. There are some contraindications for MHD, especially history of breast cancer or estrogen-dependent tumor, hormone-dependent tumor. If the patient got breast cyst, family history of breast cancer, okay, can they use hormone? The answer is yes, they can, as long as they don't have breast cancer. If the patient got stroke before, BD before, unfortunately no, because their risk is higher already, means that their vessel is not healthy anymore. Undiagnosed uterine bleeding, please settle it first, see whether you are dealing with uterine cancer or anything else. So please settle it. A significant cardiovascular disease means that their vessel is gone already, so you can't use hormone anymore. So for those that cannot use hormone, contraindicated for hormones, or memang despite your counseling, they don't keen for hormone. Okay, so you have no choice to start them with the non-hormonal preparation. So these are probably the risks of non-hormonal preparations. Fezolinetant is the one that now hopefully coming soon to Malaysia by third quarter of the year. It launched in Singapore last year already. So this one neurokinin 3 antagonist. So this is one that's specific for vasomotor syndrome. So those who are exam, please go and Google a little bit, read a little bit, because if you get me, I'm going to ask you this. Herbal supplements, Bumbi, we've got so many else, anything else, Nutrafem. Okay, now let's go to the topic today, MHT and gynae malignancy. Why I need to cover the first half of the topic? Because that is the one that you must know. Okay, that is the one that you must know. Same thing like management of third degree UV polyp, stage 3 UV polyp, you must know. Okay, stage 3 UV polyp during pregnancy, aiyo, so rare. So rare, you ask that question for what? Okay, you hardly see one. Stage 3 pregnant, 36 weeks, the cervix is outside the vagina. Hello. Hello. Okay, so the first half of my topic you must know. Okay, now coming to a more specific one upon your request. So let me brief you through this. You know that gynae cancer getting more and more. Okay, you can see here up to 400,000 of premenopause women and 8,800 postmenopause women diagnosed with gynae cancer every year. It's in a low income country, cervical cancer still remain the most cancer, and high income country uterine cancer because of diabetics, hypertension, things like that. So estimated around 1.3 million of gynae cancer diagnosed every year. So it really depends on tumor type and stage. Treatment usually includes hysterectomy, with or without BSO. We should usually with BSO, that's why you get surgical menopause. And therefore, the patient can have premenopause because of surgical capsule. Let's go to the first one, endometrial cancer. Most cases of endometrial cancer are diagnosed either menopause, but it can occur in young women, especially those obese PCOS patients or with the familial syndrome. The majority of endometrial cancer are diagnosed at the early stage, FIGO 1, 2, and so have a good overall prognosis, and the cancer survival is getting higher and higher. So treatment of endometrial cancer, we know the esophageal hysterectomy, ESO, okay? So what is the data regarding endometrial cancer? So there are limited data regarding the woman with low grade early stage endometrial cancer may consider systemic or topical estrogen. May consider early stage only with the low risk of recurrence. But in the high risk recurrence advanced disease, hormone is not recommended. Okay? If the patient only have atypical hyperplasia, endometrial hyperplasia, is not cancer yet after your surgical menopause, capsule, can you start hormone? Yes, because it's not cancer yet. Okay? So a very general term, early stage endometrial cancer might consider. Advanced stage, no. Okay? Not sure, go for non-hormonal first. Okay? Try non-hormonal first if you want to save your headache. Uterine sarcoma, we know that stroma or mesenchymal sarcoma are rare tumor. Most cases diagnosed after menopause, and this tumor may be hormone dependent. So estrogen, progesterone receptor testing can be taken to guide the diagnosis. Unfortunately, there's no clinical trial data available to tell you yes or no. So the answer is no. Okay. For uterine cancer, no hormones because it's estrogen dependent. Endometrial cancer is estrogen dependent. Early stage, low risk of recurrence unless the menopause symptom is so bad that only hormone can help her. She already go into depression. Only then you consider. Otherwise, for this group of estrogen dependent cancer, go for non-hormonal as easier, as simple as that. So this is happened in our CBG guidelines. Menopause hormone is not advised after surgery for endometrial cancer because potential stimulating any cells that left after surgery. Okay, but in other publications, early stage, very bad menopause, quality of life affected, depression, without hormone she will kill herself, then you consider after a lot of counseling. If not, go for non-hormonal. Ovarian cancer, we know that there's few types of ovarian cancer, epithelial, most common, and this cancer often occur after menopause, but also can be pre-menopause. And epithelial cancer, you have so many subtypes: serous, mucinous, endometrioid. Let's go through one by one. Endometrioid ovarian cancers are potentially estrogen sensitive, but MHT appear to be safe again in early stage cancer. Okay, but in late stage 2, 3, 4 cancer, you might not want to consider MHT. So early stage, after your surgical resections, the risk of recurrence is very low. You might consider, again, same scenario, menopause affect the quality of life, patient go into depression, maybe you want to kill herself. Okay? Otherwise, try non-hormonal first. Okay? So make life simple. Clear cell mucinous carcinoma, estrogen replacement is a reasonable option, again for low risk tumor, early stage. Otherwise, you really don't want to start hormone in this group of patients. Borderline malignant tumor often affect younger women because of the survival rate is very good. Unfortunately, again, there's lack of data, but would not be unreasonable to consider. Means that negative, boleh lah consider. But again, you see now in this kind of dilemma sensitive cases, you really need to have a very clear indication. The counseling is important, your documentation is important. You want to involve your gynae oncologist, your oncologist to start hormone. So because of that, non-hormonal first lah, easier. Ovarian stem cell tumor often affect young women. Fertility preserving surgery is very common. Prognosis is very good. So there's no contraindication for hormone because this is not estrogen dependent. Granulosa cell tumor, yes, most common ovarian sex cord tumor. They also estrogen secreting tumor, estrogen dependent. So you don't start hormone in granulosa cell cancer. Confused, but in the exam, trust me, not every lecturers or your examiner know as detailed as this. So the general sentence will be, as always, the benefits of menopause hormone for women who undergone premature menopause through cancer treatment need to be balanced against the risk. MHT does not appear to be associated with harm, as does not appear to increase overall disease-free survival in ovarian cancer, early stage, and germ cell tumor. But conscious is required for both systemic hormones in women with advanced disease and their hormone dependence. Okay? So you forget about the few slides, simple principle, estrogen dependent tumor, no hormone unless hormone is very, very needed. Okay? Otherwise, try non-hormonal first. Okay? Non-estrogen dependent, early stage, right? Risk of recurrence is low. Start lah, tak ada masalah. Okay? So this is in our CBG guideline. Risk of ovarian cancer, long-term menopause hormone has remained inconclusive. Okay? This is 4 years ago lah. Hopefully the next year we come up with a new CBG. We are going to have more detail like I told you just now. We are going to subgroup into the different subtypes. So that is more detailed. This was the CBG a few years ago. Cervical, vaginal, vulva cancer, easy, non-hormonal dependence, so no issue. Once you underwent treatment for hysterectomy for your cervical cancer, and patient can be started on systemic hormone or local hormone, especially local hormone because of radiotherapy. very dry vagina, you can start with local gynophore, for example. Okay, still survive? Okay, now benign gynecological conditions like fibroids or endometriosis. MHC and uterine fibroids. Okay, the growth of fibroids is influenced by estrogen. This one we know. Typically, they enlarge during reproductive years. We know. Okay, they hardly enlarge during menarche, before menarche, yes, and generally tend to shrink follow menopause. Very common sense, very make sense statement. So at 6 month follow-up, some of the fibroids size vary. Some reduce size, some increase in size. So this is what we observe also during our clinical. And if they increase in size, average they increase around 1.2 cm over 2.5 years. General guys. So generally believe that symptoms associated with fibroid will diminish after menopause. So why is this segment important? Means that if you have perimenopause 48, 49 with uterine fibroids, if patient is asymptomatic, the fibroid is not so huge, you can actually opt for conservative management because the fibroid size tends to reduce after menopause. So many studies show MHT has no significant change in the fibroid size. Okay? So it's not contraindicated to give MHT with women with uterine fibroid. So we can give MHT. So study reporting major increase in fibroid size frequently use different types of progestin, especially hydroxyprogesterone acetate. You shouldn't consider MPA anymore lah, to be honest. Progesterone, like I tell you, utrogestan or dydrogesterone for breast cancer favorable outcome. But in this case, Tibolon does not significantly affect the myoma growth. Okay, as compared to conventional estrogen progesterone versus Tibolon, Tibolon have a better favorable outcome for fibroid. Okay. So for your information, those have stopped bleeding, those have stopped menses after menopause, Tibolon versus estrogen progesterone, I prefer to use Tibolon usually. Why? Okay, Tibolon has the better outcome in the sex, function, libido. Tibolon does not increase the breast mammogram density, better detection of breast cancer. Tibolon doesn't affect the fibroid size. But unfortunately, Tibolon only can start after menopause. You cannot start during perimenopause, otherwise your menses will be haywire. Okay. So CBG, menopause hormone, is not contraindicated in women with fibroid. However, if you give hormone, the fibroid size increase, especially increase in size significantly in a shorter period of time with vaginal bleeding, okay, you might not only consider the effects of MHT, but you also need to rule out uterine cancer. Okay, so with or without hormone, you need to rule out uterine cancer. MHT and endometriosis, we also agree that MHT is considered the most effective treatment for menopause symptoms after endometriosis surgery. So after endometriosis surgery, example surgical menopause already, Tapso done for endometriosis already. In the usual case, you only start estrogen only, but in this case, you are going to start estrogen progesterone or Tibolon until the age of menopause, around 51. Only then you change to estrogen only. Okay, so this is the only exceptions that after hysterectomy for endometriosis, you are going to still start estrogen progesterone or Tibolon until the average of 51. Then you consider estrogen only, or you just continue with Tibolon. Okay, this is especially true for endometriosis patients. A lot of patients are young, 43, 44, you did Tapso already for endometriosis. Sexual function is very important for them, so Tibolon is better. So you just start Tibolon only, no need to change really for the next few years. Okay. For those that want to study further, so this is a very good paper, practice in menopause hormones with benign condition and cancer. Unfortunately, this is the paid version. So I asked the library to buy for me one, cannot get from Sci-Hub. So for those that you can, if you want, you tell me, I'll share you the full paper. Okay, so this is appear in the paper. So basically, almost the same like what I told you just now. Okay, so this is the conclusion of the paper. They are rare, benign, malignant gynecology condition that pose a challenge in managing menopause symptoms. Hormone dependence nature raised the concerns about symptom recurrence and malignant transformations. So the discussion regarding MHT use in women should be individualized and patient focused. Like I told you the basic principle, non-hormone dependent, no problem to start hormone. Hormone dependence, early stage, low risk of cancer, if possible non-hormonal first, cannot then hormonal. High risk recurrence, advanced stage, no hormone again, unless really no choice. So with that, last few slides, this is the IMS Congress that happened in 2024 Melbourne. You can see here, this is probably the approach now to talk about menopause hormone. Okay, you talk about sleep, mood, cognitions, you talk about perimenopause management, you also talk about cancer and MHT. So again, it's written here, prioritize non-hormonal therapy. We have quite a number of options now. We have herbs, we have fezolinetant now coming soon. Talk about cardiovascular health, talk about osteoporosis, and not to forget urogynec problem. So you really want to have a better, good quality of life among the couple, especially the wife. Okay, happy wife, happy life. Okay, kalau happy husband, suspicious wife. So the husband will keep on smiling when you go back. We really want to see a Wonder Woman. We don't want to see mommy. Okay, somebody going to kill me now. We want to see Haji Pupu. Don't ask me the cartoon is who, okay? I won't say it's her. Okay? We don't want to see mommy la Pupu, okay? Okay, so hormone is very important. Management of menopause is very important. I hope that you guys really please concentrate and focus on menopause. It's a very easy topic, very simple topic, and yet it's very common that you need to use it for your own managing your mother-in-law, your wife, or even your consultant. So together we can make a difference. That's why you are here, I'm here. So conclusions, okay? So I'll skip this. Same thing like what I tell you. Thank you so much.
Thank you so much, Professor Dr. for such an eye-opening lecture. Any live question from the audience?
You ask me downstairs because Prof. Mahana is here already.
Okay. Due to time constraint, we will proceed with our next lecture of the day. So for our next lecture, we are going to hear on the rhesus isoimmunization. It will be given by Professor Dr. Rahana Abdul Rahman. She's the head of the MFM unit, Hospital Chancellor Tuanku Muiz. Without further delay, I would like to welcome Prof. Rahana to give a lecture on rhesus isoimmunization.
Okay, I don't enforce. But I'm not on MHT.